So hello and welcome to another Pw2002 video. This one we're going to look at working in partnership with patients and clients and carers in relation to self-administration and management of medicine. And this is going to be referred to throughout this presentation as Sam. It is quite a long PowerPoint, so I probably will just discuss in general terms as we go through. If you want to go back and have a look at this PowerPoint in more detail, go back, have a read of some of the slides in a bit more detail, take a bit more time over them, because I'm probably going to gloss over some of the slides, tell you to link to some of the key things that are on there. This is going to link specifically into your assignment for Learning Outcome 4 when we're thinking about supporting our patients or working with them through the self-administration of medication. So it is relevant for your assignment. Obviously for this I'm going to talk about it in general terms, or I might use some examples, whereas when we have the discussion seminar later on we'll start to think a little bit more detail about your chosen medications and how Sam is actually going to relate to those medications that you've chosen to look at for your assignment. So throughout this presentation, we're going to look at a definition of SAM. We're going to think about the national drivers to promote it, so why we actually have it. We don't always think about it as something that has been kind of promoted and pushed. We think about it as just something that happens. So it's kind of important to have a look at some of the background and some of the underpinning thoughts around it. We're going to look at some benefits for it. Again, this is going to help to support that Learning Outcome 4 for you in your assignment. We're going to look at some of the factors where a patient might not be able to self-administer, and we're going to look at the roles and responsibilities of the practitioner in relation to self-administration. So as I said, we're going to cover quite a lot, but I'll probably some slides I'll go into more detail, other slides I'll just introduce you to, and then you'll be required to have a look at some of the resources or to look at these in further detail and how these are going to specifically apply to your chosen medications. So what is self-administration of medication? So this is basically the system in which a patient administers their own medication. It is as simple as that. And this is defined from the National Prescribing Centre in 2008. And we want to think about, well, why did we need to introduce a self-administration or SAM kind of legislation or thoughts or policies and procedures? As I said at the beginning, isn't it something that patients just do? They take their own medications because they have to. But actually, the thoughts and the underpinning behind the self-administration of medications was recommended by the Audit Commission in 2001. We had to think about, why are we actually supporting our patients to administer their medications? And actually, if our patients can administer their own medications within their own home or within a community setting, why is it that when a patient comes into hospital, it's a requirement of the practitioner within the hospital setting to actually administer that patient's medication? They've gone in for something as simple as a toenail removed or something quite minimally invasive, but they still can't take their own medications because they have to be given by a practitioner. It all got a little bit confusing, and there was lots of debates around it. So the Audit Commission actually looked at this in a lot more detail and thought about, how do we support our patients to not only maintain their own medications within their homes and community settings, but also within hospitals. There were also many other drivers for self-administration of medication. The NMC, within their Standards for Medicines Management documents, which is linked to in your resources, welcomed and supported the self-administration of medication by patients or carers wherever possible, and that it's the responsibility of an NMC registrant or a HCP registrant or whatever regulatory body a practitioner is bound by. And these practitioners can assess patients as suitable to self-administer their medicines for both in hospital and at home. So really one of the, as well as the first document that we looked at from the National Audit Commission, we're also getting support from our regulatory bodies, and there's also further support from the national service frameworks. Look, when we think about the National Service Framework for older people in particular from 2001, which also supported self-administration because it helps to meet the requirements of this National Service Framework and medicines for older people, and it helps to implement medicines related aspects of the National Service Framework for older people. So it's really, really important that when we think about our self-administration of medications, that we're not just saying that patients are doing it because we have. We're actually starting to think about the fact that yes, patients have always taken medications, hopefully as prescribed, or take medications that are off the general sales list as needed. But actually these days there's a lot of legislation or framework underpinning that supports self-administration of medication and helps the patients or practitioners to understand why it's so important and what our role is within that. Another thing that actually helps to underpin the self-administration of medication is a document called Pharmacy in the Future, implementing the National Plan, a programme for pharmacy in the NHS from the Department of Health in the year 2000. And this document, again with some of the other ones from around that time, helped to set out the role that pharmacy services will play when they changed the structure of the NHS. And it outlined the government's plans for giving patients better access to pharmacy services and to help them manage their medicines more effectively. So this also underpinned, or this particular document helped to underpin blister packs and dosette boxes, pharmacies actually providing dated and timed medications for patients so that they can self-administer these medications in a lot more competent manner. So if a patient is taking, 10, 20 medications a day, rather than having to remember, have they taken the medication, have they taken the right one at the right time, the pharmacies were actually providing these dosette boxes or blister packs to help a patient actually safely administer their own medication at home, to make sure that they took the right dose at the right time, thinking back to our 5Rs, that we're not missing anything out, that these patients feel confident to take their medications as required. And this also hopefully helped to limit the burden on some carers, family members, external care agencies to go in and help these patients if they felt comfortable, if they were deemed competent, to actually take their own medications at the right time. There's an awful lot of thoughts around dosette boxes and blister packs and things. And these days, with more and more people having access, to these smartphone things, it's really useful these days that you can get dosette boxes that link up to phone apps. So it might be it's a phone app for the particular individual that says you haven't taken your pills today, or it's a phone app that links to relatives or carers that actually says, your grandma or your mum or Joe Blogs hasn't taken their medications today because they haven't opened the dosette boxes. So then either the app would remind them, or that the app would tell you, then you could contact that patient to say, why haven't you taken your pills today? Is there a problem? Gives, people an extra kind of highlight as to, is that person safe within their own environment? Is there a reason that they haven't taken the medications? Is it just something as simple as they haven't got up in time to take the morning medications yet? Or has there been something a little bit more sinister occurring and actually you need to investigate it a bit more? So, there's lots and lots of developments when we're thinking about the roles that not only us as practitioners, but also our wider multidisciplinary team, for example, pharmacists, thinking about that. There'll be more and more discussion, and we'll have some of these discussions later on. But when we're thinking about, the future of pharmacy and the future of things, I'm sure if many of you are like me on Facebook, you've been having your personalised adverts, And I've been getting a lot of adverts because specifically I've been looking at a lot of medicines management stuff for these lessons. I've been getting them about, personalized 3D printed vitamins that are, they'll give me a blood test and then they will 3D print the vitamins that are going to meet my specific needs. Well, that still seems a bit, sci-fi and futuristic. But actually, when we think about, what's going to happen in the next 20, 30, 50 years, will it be that we won't have pharmacies in the traditional sense anymore? And we'll all just have a 3D printer in our kitchen. And every day we'll just press a button and it'll 3D print the medications that we need. And we'll just be delivered the appropriate bits to put into the 3D printer. Or it'll be, like my printer talks to the internet, it talks to a server, and it sends me more ink when my printer decides that I need ink. So will it be that these 3D printing machines talk to a mass thing, and when they know that they're running out of pills, we'll automatically get a delivery of whatever the component is to 3D print my pills for that particular day? So when we think about this, there's an awful lot of future in the self-administration of medications and what's going to happen. So it is really interesting to look at some of these things and the history of what's happened and what might potentially happen in the future. So when we're thinking about self-administration of medications within a hospital, this is one of the things, we've all seen if we've been in hospital, we work in hospital, we visited people in hospital, the new bedside cupboards that have the lockable part in it. And this is to allow patients to continue to take their own medications while in hospital. The philosophy of the underpinning point of this is that it encourages patients' autonomy and independence. They take their own medications at home, so they should be able to take their medications themselves in a hospital. Doesn't necessarily work like that because patients aren't always given the ability to have their own key to that locker. It's still kept on the master key set that the nurse in charge would carry. So they'd still have to ask somebody to come and unlock that locker to take their medications. But one of the biggest positives for the NHS within being able to allow patients to self-administer their medication in hospital is the cost reduction for providing patients with all of their medication if they go into hospital. It's enabled medication trolleys to carry a basic ward stock as opposed to a massive ward stock of every medication they may or may not encounter on any given day because of the comorbidities that their patients might have. So while it might not necessarily be being used as well as it could be doing in some hospital settings, it does have implications for the NHS wider for cost implications for allowing patients to use their own medications. It also allows patients to be discharged quicker if they come into hospital with their medications, that if they haven't had any changes to their natural medications, that they don't have to wait for discharge pharmacies or discharge prescriptions to be completed by the pharmacy, in that they can just go home with the medication that they brought in. And if there are no changes, they don't have to be waiting for this. So when we're thinking about smoother discharges for patients, it can have a big benefit. So thinking about our benefits and continuing from these benefits to the NHS, we can also think about what are the benefits to the patients. So obviously if our patients are looking after their own medications, it can give them a better understanding of their medications. And if they've got a better understanding, it can give them a greater compliance. By giving patients the autonomy to actually take their own medications, it improves patient education. So again, you're also improving concordance, you're improving this compliance, as we've said. It improves communication and trust between the hospital team and patients. The patients are involved and being autonomous for their own treatments. And if patients aren't happy with medications that they're being taken, it can enable timely discussions of changes. You know, if patients feel that they are empowered to take their own medications, that they're given more understanding and education around their medications, that they're more likely to want to discuss changes to their medications or take part in medication reviews with their practitioners. It encourages a familiarity with their medications. Patients are a lot more aware of what they're taking and why they're taking them, which helps to become a better part of their rehabilitation. If they need to take medications at certain times or for certain conditions, again, it helps them to understand what they're taking and why they're taking it. And therefore, if a patient has more understanding, more knowledge, more education, it helps to reduce the risk of medication errors. Patients are more aware of what they're taking and when they're taking it, so they're more likely to not have medication errors, they're more likely to take their medications at the right time, and it helps them to understand the storing of their medication. So not just within their home setting, but also within a hospital setting. So as we've said, it assists on the rehabilitation process and the discharge process if they're within a hospital, and it promotes improved patient satisfaction. When patients feel empowered and part of their own care, they're more likely to be satisfied with the care and the information that they're receiving from their healthcare providers. So it's really, really important that they aren't just told you must take this medication at this time, as maybe historically patients were told, that they're actually part of that process, they're part of that discussion process with their prescribers or healthcare practitioners, so they can make decisions like, I do or I don't want to go down a medication route. Is this medication going to be better for me to take in an evening because I'm more likely to remember it, or because it makes me a little bit sleepy? Patients feel that they can have these communications a lot more. When we have these information, when we have this improved patient satisfaction, we also have increased patient empowerment. So as we said, this helps our patients to have a better understanding of their medicines. So if they don't feel comfortable, if they don't feel safe, we can have conversations with them. It helps them to identify any problems that they might have. If they don't like having 20 different boxes of medications, it can open up conversations around, well, have you thought of contacting and speaking to your pharmacist around getting a blister pack, or around getting Dosette boxes, or around getting some of these new things, like I said, like apps and other things, to help support our patients in taking their medication at the right time and in the right way. It improves staff awareness of patients' ability to cope. So again, if we're giving patients new medications to take home, if a patient is in hospital, if a patient can't cope with taking their medications from their own cupboard under the observation and guidance of a practitioner, this can help the staff to actually highlight or signpost any issues that they might have, to actually say, maybe this patient doesn't have the competence or the confidence to actually be taking their own medication. So do we need to identify any specific needs for discharge? Do we need to get carers or relatives to support them? Do we need to make sure that they've got Dosette boxes or blister packs? And again, if we can improve medicine's compliance after a discharge, it might help prevent further readmissions to hospital. If a patient wasn't medicating or using their medications appropriately, and that was one of the things that led to the admission into hospital, it might be that once we've supported and helped and talked, this is going to help to prevent further readmissions. They can practice in a safe environment, and it helps them to be comfortable. So again, if a patient is in control of their own analgesics or pain medication, or medicines that need to be taken before or after food, in an environment like on a hospital where ward rounds and medicine rounds are done within a period of time, but due to other constraints on the ward might not actually occur when they're supposed to occur, patients might not be getting medication at an appropriate time. So patients being able to administer their own medications might actually help to support patients getting analgesics every 4 hours if they are required, to try and reduce this breakthrough pain, or food that needs to be taken before or after food. If a medicines round is planned to be after dinner, but actually their medication needs to be taken before dinner, patients can actually take their own medication and be aware of what they need to do to take it safely. There are lots and lots of benefits for SAM for relatives and carers. If you're supporting a patient or supporting a relative who's taking their own medications, if you're aware of that they know how to take it, when to take it, why to take it, it can help to reduce your relatives or carers' anxieties. It helps the patient to be involved in their own treatment. It helps the relatives or carers to have an improved awareness of the patient's ability to cope. Can they take their own medicines as prescribed or as advised, or do we need to set something up to help support them? It can give relatives and carers an improved knowledge of their loved one's medication. Just like we're doing these medicines management modules to help you build this better kind of basis of knowledge. Again, being part of a self-administration of medication route can help relatives and carers to improve their knowledge of medication. As we've said earlier, it can improve communication and it can reduce the risk of readmission to hospital. And when we're thinking about the bigger picture and we're thinking about hospitals themselves or NHS trusts, it can highlight needs for discharge if there are any issues. It can assist with the concordance of patients. Obviously, if we're not having to carry every single medication at all times and we're not having to replace these medications on discharge, it can help financial savings for trusts. It improves medicines compliance after discharge. If patients are in charge and in control of their own medications, they're more likely to understand and follow after they've been discharged. As we've said earlier, it can identify patients with problems managing the medications. It can have a potential to reduce the amount of nursing time spent administering medicines. If medicines rounds take a long time because nurses have to keep giving certain medications at certain times and you've got one trained member of staff, if they can be supported in other ways, or other practitioners can support patients taking their own medication, it can reduce the amount of nursing time spent administering them. And as we said, it can have the potential to reduce the number of readmissions due to problems with medicines, because hopefully if there are any issues, they've already been identified and support packages or other people have been put in to actually assist the patient in taking their own medication. So when we're thinking about SAM within the community, it can also help us, multidisciplinary team working between our acute, our primary and our community settings will improve understandings of patients' needs. If we're all working together and we're aware that the patient is the centre of their own care, we're now able to say, our acute and our primary care can communicate with our community to say that actually they need support or they don't need support, which can help with care planning. It can have an increased potential for patients continuing improved self-management of medicines in the community. If patients feel empowered to take their own medications appropriately because they've been supported and their confidence has been built, they're more likely to continue this within their own homes appropriately. And this helps medicines to be taken at the right time. And it might have a reduction in the requirement of some of these compliant aids. If patients didn't feel confident beforehand, so they were relying on things, it might be that actually now we've given them the support, the information, the knowledge and the confidence, they actually feel in better control of their own medications and their own kind of life going forward around any conditions or long-term conditions that they may have. So moving on from some of the thoughts around it, when we're thinking about self-administration of medication, is consent needed? You know, everything works on consent. Everything is around, you know, what we should and shouldn't be doing as far as being a medical practitioner. But actually, should we be getting consent as to whether a patient can take their own medication? That seems a little bit odd in some ways. But actually, yes, we should be getting consent as to whether a patient should be participating in taking their own medication. And actually, the Duthie report in 2005 recommends that not only should we be getting oral consent from patients taking part in self-administration within hospitals, but we should also be getting written consent. They should be signing to say that, yes, they are happy to continue to medicate themselves in a way that they would have done at home. Now, I have to say, I'm not 100% sure on the documents that are using, because the last time I worked on a ward, I can't remember actually seeing whether, you know, any documentation that patients had to actually use a written consent. It was just we just took a "Are you happy?" oral consent, but maybe that depends on local trust policies and procedures as to whether, by checking that yes, you've had that discussion that meets the consent requirement, or whether or not you should be having a written or signed piece. So as it said, local trust policies and guidelines should be followed. And it's important that patients are aware that participation in self-administration of medication is voluntary within hospital. And if they just want to be given their medications by the staff, well, actually they can, because they can withdraw it at any time, and then the practitioner can take back over the administration of medications. When we're thinking about accountability and legal issues, we've got to think about, you know, the things that we are underpinned by. And obviously our duty of care is to avoid, whether by acts of omission or by acts of obvious, is that we can't cause injury or damage to a person or property that can be reasonably foreseen. So with self-administration of medication, there needs to be a consideration around the law of negligence. So are we taking the patient's kind of say so that they have taken their medication? If we're relying on them to take their medication adequately, and we're signing to say that that patient has taken their medication, are we sure that our patient is following the rules or taking their medication as required? Because obviously it's very hard to document that if we're not aware of when and how a patient is taking their own medication. So the NMC in 2007 has stated that patients on self-administration of medication programs within hospital settings should have access to professional support. So actually, when we talked on the last slide about it can free up extra nurse time because we're not having to administer medication, that actually, you know, the reasons why nurses carry the keys is so that patients can actually have this support from a practitioner when they're taking their medications, to feel that they've got the confidence to do it. It might just be as simple as somebody opening the locker, giving them the packet, and then the patient does the rest before the practitioner relocks the cupboard. Or it might be that actually the patient wants to have that process talked through with them, that they are talking them through, well, I'm taking this one for this, I'm taking this one for that, and then the practitioner watches them take those medications. And as it says, you know, nurses are also accountable, or other healthcare practitioners who are involved within the support of patients are also accountable to providing the best possible care to patients in relation to medicine administration. And some patients might need more appropriate care than others. So again, it's really important that every patient is treated on an individual basis. That just because one patient feels really comfortable doing this doesn't mean that they all will. And it's really key that we treat every patient as an individual and we focus on our patient-centered care to make sure that our patients are treated in the way that is best for them. So which patients can participate in self-administration of medication? So any patient can, as long as they've had a thorough, robust and objective assessment of their ability to self-administer. Now obviously this is kind of objective when we think of a robust assessment of their ability to self-administer, because within the community setting or if a patient's been to the GP, a patient would normally just be told, I'm going to prescribe this, and then it's done. So again, it's back to what are the local trust policies and procedures when we're thinking about their definition of a thorough, robust and objective assessment. Is it just asking the patient if they're happy to, or is it actually something a little bit more detailed? And for any patient who's admitted to hospital, it's assumed that they can self-administer their medication unless the assessment indicates otherwise. So again, it's back to what is this robust assessment? What does it mean? What does it take form of? And that this assessment should apply to all medicines, including inhalers and creams, which patients may have been allowed to use independently in the past. So if a patient puts their own creams on or puts certain things on or uses their inhalers as required, again, it's key to support the patients in feeling that they can use these as they may need to, following their own self-administration of medication care plan. The aim of the assessment is to determine the patient's ability to self-administer safely, to ensure there are no unacceptable risks, and to identify and resolve any potential difficulties. So again, in hospital, it's really key that patients are taking their medications appropriately, because any issues or side effects or problems that are observed need to be identifiable as to something that may or may not have happened. So if a patient is saying that they're taking their medication as prescribed, but they're not, for maybe something like blood pressure, and then their blood pressure is consistently high, this obviously might need to then be investigated further, but it might be an investigation something as simple as, is the patient taking their blood pressure medication as prescribed? And if not, that might be the reason why their blood pressure is high. So they might need more discussion or conversation or education as to why they should be taking their blood pressure medication. And then obviously this can be assessed on a daily basis. And it's really key that they follow the initial assessment of the level of self-administration that's been agreed. Is it that patients can take certain medications on their own, but other medications have to be administered by the practitioner? Is it that they can take all medications, or is it that they can take none? So obviously it's key that we follow the care plans, especially if they've been done in discussion with the patients. One of the key things, especially within healthcare, is the self-administration of Parkinson's disease medications. And it's critical for the patient with Parkinson's disease that they get their medication at the correct time to maintain the control of their involuntary movements. Different patients will have different medication requirements. So on average, these patients take their medications approximately 4 times a day. But some patients need to take medications up to 14 times a day. Now, can you imagine a medical practitioner having to go to a patient 14 times to get that medication given appropriately? And if a patient needs to take these medications at very specific times, and they have it down to a fine art at home, they've set alarms, or they're just aware of things, or they know when to take them, it's really important that just because they've been admitted to hospital or put in a different setting, that they are following their normal routines, and that they aren't waiting what could be up to half an hour for a practitioner to come and help them or to administer something, which could really put their routines out of whack, or it could actually cause them to have, massive increases in symptoms. And there's been a lot of research into this, and most of these studies have concluded that approximately 50% of the patients that are given Parkinson's medications get them at the right time whilst in hospital. So actually, that even though that's trying to sell it as a positive, that actually means that 50% or half of the patients don't get their medications at the right time, which is actually a massive issue when we're thinking about our patients, that at home their symptoms and their conditions can be maintained somewhat, amazingly at home. And just because they've come into hospital, actually, they're expected to have a lower quality of life because we can't get to them at the right time to give them a medication. So it's really, really important that we're thinking about, the benefits of self-administration of medication for our patients and for their individual conditions. Some of the things that we have to think about when we're thinking about self-administration of medications are things like, it's not actually that person's responsibility for administering medication at home. It might be that their partner, that a relative or a carer actually administers them or supports the administration of medication at home. And actually we haven't had those discussions, and we're expecting a patient to do something that they might not do at home. The patient might have acute confusion or delirium. They might be able to take their medications generally. However, for this period that they're actually in, it isn't appropriate. It might be immediately pre or post surgery, so again, they might need that support and that help. They might have a cognitive impairment, which again is having impacts upon whether or not they can do it safely. They might have a history of drug or alcohol abuse, or a previous history of overdose or self-harm. So again, the patient might need to be assessed for mental health issues or a capacity. So actually, these might be key underpinning factors as to whether or not a patient could self-administer within a hospital or other care setting. They might be paediatrics, they might be children, so again we wouldn't expect children particularly to be in control of their own administration of medications, but it might be working with the family or other guardians to actually support this administration of medication. The patient might have been deemed unable to participate due to a lack of capacity that's actually been defined under the Mental Capacity Act. Excuse me. They might have physical disabilities which prevent the self-administration of medication, and they haven't then been discussed around, different adaptations that could be made to help them to actually administer their own medications. Or they might have reduced cognitive capacity. There are also some medication factors which can also influence whether or not a patient can self-administer medication. So it might be an unstable medication regime, or it might have variable doses. It might be something that's cytotoxic. It might be something like warfarin or steroids that again have to be maintained very, very precise managements or levels. It might be a required medication, so this might be a positive or a negative as to helping our patient self-administer. It might be that it's safe to take it then, or it might be that actually we need to be having the patient ask for it rather than keeping it there because they might be taking it all the time as opposed to when required. If we're in a hospital or other health setting, it might be that it's a controlled drug. So it's not appropriate for us to keep a controlled drug in a certain place for the patient to administer themselves. It might have to be locked away in a certain place because of policies and procedures. It might be that it's parental medication or that it's antibiotics. It might be that the item requires refrigeration, so again, we can't leave it with the patient in the patient's area. It has to be kept in an appropriate fridge. Excuse me. Or it might be a medication that's once only. So again, you don't want to leave a store with the patient because actually it's only a once-used medication. So it's better just being given by that practitioner the once when it needs to be used, and then it doesn't need to be looked at again. So there are lots of different ways that self-administration can be made more effective. So it might be the use of the patient's own drugs. So they're asked to bring their own medications in with them, and then they either take their own medications or the practitioner would support the taking of medications. This is then going to be assessed by the pharmacy staff on admission, and then it can be used if suitable. This is because obviously we don't want patients to be taking out of date or inappropriate dosages of medication just because they've brought them from home, and these might be the ones that they're bringing from home and taking it home doesn't necessarily mean that the patient has checked use by date, that the patient's checked dosages and things like that. So it's really key that if you are going to use any patient's own medications in healthcare settings, that they are looked at by the pharmacy staff or an appropriate practitioner within the healthcare setting to make sure that they are appropriate to be used. There's one-stop dispensing. There might be one-stop dispensing on the ward. Again, this might be maintained by the pharmacy staff. It might be maintained by a practitioner on the ward. And they're given their medicines labelled for discharge with the directions, with the patient information leaflets, but they're also given a personalised patient medication record, and they will then document on this record as and when they've taken their medications. And that each patient should have been assessed to whether or not it is appropriate for them to self-administer their medications. We need to make sure that the patient has access to information leaflets and medicines reminder cards, and that you've had a really in-depth discussion with the patient about any side effects or contraindications that they really should be aware of as to whether or not these medications are appropriate, and to help the patient make that informed choice as to whether or not they want to continue on this medication pathway. There's a couple of levels that we have to think about of supervision with self-administration of medication. So level 0, the patient is not self-administering or not admitted on any regular medication. Might be level 1, the nurse has possession even of the key to individual bedside medicine lockers and administers the medication from the locker. The nurse documents on the prescription chart to record the medication administration. Level 2, the nurse has possession of the key to the bedside medication locker. The patient administers their own medication, however this is under the supervision of the nurse. The nurse will then document on the prescription chart to record that the medication was taken. Level 3, the patient has possession of the key to the bedside medicine locker and is responsible for the storage and self-administration. The patient completes their own chart to record that the medication has been administered. Patients are able to move both up and down the levels depending on their abilities and their changing needs. So a patient might be on level 1 or level 0 if they are post-surgery. However, as a patient starts to recover and starts to become more and more able to have a normal quality of life, maybe 24-48 hours to post-surgery, they might move from a level 0 or a level 1 down to a level 3. And a consent form for Sam must be signed by the patient, and the assessment should be reviewed daily. So again, this is really key, that we're going back to our trust policies and protocols and thinking about what are the things that we have to do to ensure that our policies are followed and that our patients feel empowered, but also that we're documenting everything that needs to be done. So thinking about our safe and secure storage of medicines, as we've talked about previously and as we've talked about through this presentation, how do we store our medications for the self-administration within a hospital? So we might be that we've got bedside medication lockers, and these must be able to be lockable and then either have the key that is supported by the practitioner or the key which the patient will look after themselves. And to minimise the risk of self-administration error, only medicines that have been labelled for that individual patient should be stored in the bedside locker. Now, I know that when we're thinking about the self-administration of medication and these bedside lockers, that we've all heard stories, either the ones that we've been involved in ourselves or stories from other patients or other practitioners, where patients have inadvertently either taken medication thinking it was theirs that had been left from previous patients, or that when patients have been putting their medication into the lockers, again have found other patients' medications within them. I've even heard of patients finding controlled drugs being stored in the storage medication cupboards from previous patients, which again, obviously it's a previous patient's medication, but it's also a controlled drug and should have been stored under the controlled drug policies and not just popped in the bedside cabinet. So it's really key that when we think about this, we think about the positives, but we also think about the things that could go wrong, because obviously these could have medication issues for our patients if they think everything in their locker is theirs, but actually it hasn't been checked, it hadn't been emptied from the previous patient, and a patient is now taking medication that they shouldn't be taking. So thinking about this, thinking about our kind of conclusion to this, so what are the roles and responsibilities of the practitioner when we're thinking about the safe administration of medication? So they must have achieved a competence with medicines administration, be it that you've taken this course, be it that you've followed your trust policies. You might have needed to take further training or competence to be able to assess patients for self-administration. You need to be aware to support and educate your patients or carers about self-administration to help them make an informed decision. As I said, you might need to undertake the assessments for their suitability. You might need to act as a link person between all members of the multidisciplinary team for the self-medicating patients to see whether or not they need support or further guidance or further equipment. The patient might need to be continually assessed, recognising and acting on any changes in the patient's condition, making sure that the patient actually understands that they can reach out for support, that they know who to talk to if they're worried, if they've lost their confidence, if they need extra equipment, and that these patients are then educated about what their medicines are for and why they're taking them. If documentation needs to be done, that any documentation, recording in nursing notes or medical notes, or having, for example, things like having to prompt the patient to take the medication if a patient's missed any doses or anything. And if there are any changes, that the pharmacists are aware so that changes to supply can be arranged. And that any medications are being stored appropriately and safely. There might be an evaluation scheme, there might be some auditing that needs to be done. So again, it might be that you're helping support the patient through that or completing that. And that somebody is responsible with the pharmacy team, with everybody else, as part of the multidisciplinary team, that ensuring that all the patient's medication is kept up to date and any discontinued medications are removed and returned to the pharmacy. That we're making sure that the patients are aware of the proper storage and disposal of medications, so that we're not having stockpiles of medications in patients' own homes, that we're not having patients using expired medications, and that we're not therefore making prescription charges or other fees that the NHS is spending going up through the non-needed prescription and dispensing of further medications. So I know this has been quite a long presentation today. Again, there's some interesting case studies to look at on the task sheets. We've got some links, as we said, into the when things go wrong, medication errors, when patients do things wrong, and so it's useful to after watching these two presentations that we've looked at for today, to go to look at the tasks. You might want to go back and look over these presentations again. Think about any questions, thoughts, feelings, worries that have been brought up by today's session. Obviously, we'll have further discussion in the seminar. We can discuss things on Teams. We're going to feedback from the tasks and the questions that are on the task sheets. And obviously, it's just being aware that the self-administration of medication section is really going to link into that learning outcome for your assignment. So think about it in relation to your own medication. Can your medication be taken safely by the patient, or does it need to be administered by a practitioner? And what are the circumstances that these may change? So I hope you've enjoyed self-administration of medication. Have a lovely day, and I'll see you for the seminar. Bye!